We are intentional about not just talking with staff, but talking with patients. How can we serve customers better? We take it very seriously at Hopkins. We do surveys and interviews with community leaders and religious leaders and patients who may be unhoused on the streets. And I will tell you, there's an underlying theme on what they really, really want. They want communication and they want compassion. And that seems to be universal across all different patient subtypes.
Hi, I'm Chris Malone, and I'll be your co-host for today's discussion. Thank you for joining us. I'd like to start by once again welcoming our friend, colleague, program partner, and today my co-host, Michael Giuliano. Michael is president of Planetree International, which is a global not-for-profit organization dedicated to humanizing healthcare for everyone through excellence in person-centered care. Welcome, Michael. What can you tell us about our guest today?
Thank you, Chris, and welcome everyone to our March 2025 Humanizing Healthcare podcast. It's great for all of you to be here. I'm really looking forward to this upcoming discussion and have the great pleasure of welcoming Dr. Redonda Miller to the podcast today. Dr. Miller is the president of the Johns Hopkins Hospital, an 1,100-bed academic medical center with more than 11,000 employees, $3 billion in operating revenue, and a dual mission of innovation and community care. Since 2016, Dr. Miller has led the hospital in the pursuit of exceptional clinical care, enhanced quality, safety, and patient experience, and improved outcomes for the larger community served within Baltimore. Dr. Miller's tenure at the Johns Hopkins Hospital has consistently recognized the organization for clinical excellence, maintaining its ranking among the top hospitals in the nation on the U.S. News and World Report honor roll. In 2019, the hospital also received gold certification for excellence in person-centered care from Planetree, and still to this day is the largest academic medical center in the world to be certified by Planetree. Dr. Miller first arrived at Hopkins as a medical student, later earning her MBA from Hopkins as well, while also serving in a number of administrative roles with the medical faculty and amongst the larger Hopkins healthcare system. In addition to her executive leadership, Dr. Miller is a practicing internist, continuing to see patients amongst her what I would imagine is an extremely busy schedule, and remaining connected to the hospital's core mission and the realities of patient care in the community. In recognition of her leadership and dedication, Dr. Miller was inducted into both the National Academy of Medicine and the Maryland Chamber of Commerce Business Hall of Fame. She's been named one of the top 25 women leaders in healthcare in 2019 by Modern Healthcare magazine, and among 100 great leaders in healthcare by Becker's Hospital Review. So we were really lucky to have her with us today. I'm sure I sufficiently embarrassed her by that introduction, but I very much look forward to the conversation. But first, I'll hand it back to Chris to kickstart us with the questions for today's podcast. Thanks, Chris.
Welcome, Redonda, and thank you very much, Michael. So, Redonda, can you get us started? We would love to hear the story of how you chose a career in medicine. Is there anything you can share with us about how that all came about?
Let me start by saying, first of all, thank you to both Michael and you, Chris, for allowing me to be here with you today. I've been really excited about doing this podcast, and I think so highly of your organization. How I got into medicine was not the usual way. I come from a family of school teachers. My parents, all of my aunts and uncles, no one really in any of the healthcare fields. And honestly, I started out at The Ohio State University thinking I would be an engineer. But I always hearken back to this incident that happened when I was a freshman in high school. I was the oldest of 4 children, rural area in Southern Ohio. And one night after dinner, my parents both became very sick, dizzy, nauseated. They thought there was a gas leak in the house, took us outside. The kids are fine. 15 minutes later, dad is comatose, mom is vomiting. I called 911, and I have this visual memory of the paramedics doing CPR on my dad. My mom and dad were both in the ICU at the local hospital for 2 weeks, and they're fine. Punchline, fast forward. They ended up having organophosphate poisoning, which is from insecticides that were old and are now off the market. But the bottom line is, I kept thinking about the doctors, the nurses, the paramedics, everyone that saved their lives. They're perfectly fine. I would have been an orphan with my siblings, and that struck an interest in medicine. That is what I wanted to do with my life.
Wow, that's a great story. I'm so glad to hear the outcome.
I always forget to tell that punchline early, so people.
Yes. But since we're going to talk so much about person-centered care today, I'm going to take a step away right now and let you and Michael kind of take us through that discussion. So go ahead, Mike.
Redonda, what a great start to this discussion, because I think what you mentioned is so critical to person-centered care and what we do every day to make great experiences for everyone involved. And as you know, healthcare has changed a lot every day and in the past few years. But that same passion that you brought into healthcare, do you think our care teams working on the front line each day share the same passion for healthcare now compared to when they entered the industry? And if not, or if we think this is waning or decreasing, how do you think us as healthcare professionals and leaders can improve that engagement amongst our healthcare staff and sort of reconnect everyone back to the reason that excited them in the first place, just like what excited you in the first place, to go into healthcare and maintain that excitement in the future?
Michael, I think 100% people still have that same passion. Absolutely.
Good.
Someone who chooses to deliver care for their life's work is a special person who's mission driven. And that I do not think has changed. What has changed has been how we deliver the health care. And over time, we've had the creep of bureaucracy and paperwork, and people who chose this feel more removed from the actual bedside and what they signed up for. We're working on this intently at Hopkins, as are my colleagues across the country. How do we connect people back to that mission? Whether it is virtual nursing or AI technologies that help alleviate some of that administrative burden, or, I could go on and on with some of the advances, but trying to get them back to what they signed up and love to do.
Mhm.
And I also think we have an opportunity to tell stories. I remember during the COVID pandemic, all of our pathology faculty and techs and staff were working overtime, developing new COVID tests, figuring out how we do it more rapidly, how do we get the reagents. We decided we would celebrate the 1 millionth COVID test that we did here at the Johns Hopkins Hospital. And we
Amazing.
had a huge party, so to speak, outdoors. And we connected it to the fact that it wasn't the 1 millionth COVID test. It was the 1 millionth life that they saved. And I wish you could have been there to see the reaction. And it's that kind of work where we really have to be intentional about connecting people back to their core.
Yeah, that's great and so well said, because sometimes we can lose the meaning of such impactful things and sort of the hustle and bustle of everything. And I like the way you said this, that we all maintain that mission and passion,
Yeah.
but it's actually the environments, the human factors that we create around people that sort of drains that bucket of excitement. So what can we do to change that? I know some things are more difficult from a government or regulatory perspective, but there's a lot of other things, as you mentioned, that we can focus on that maybe aren't difficult but make a big impact. I'd like to shift a little bit to sort of more the macro understanding of where Hopkins or what groups Hopkins serves. Obviously you have a really diverse community within Baltimore. You have a lot of patients coming internationally to Baltimore as well, serving the Baltimore residents who are predominantly, from our understanding, underrepresented minority groups to older adults covered by the Medicare program. So as a large academic medical center with these multiple competing priorities, patient cohorts, payers, how do you ensure that the really diverse needs of these communities are understood, met, and honored throughout the care you provide?
I hate to say it, but it really boils down to 3 words. We ask them. It's not my job or my leadership team's job to assume what they need. So we go out and we ask them. You know, we implemented leadership rounds 8 years ago where we are intentional about not just talking with staff, but talking with patients and hearing from them the issues they face. We pay attention to our patient experience surveys. How can we better serve customers better? And you find different answers. For instance, our international patients are maybe focused on customs, dietary concerns, interpreters,
Mhm.
and cultural differences in how they view their treatment and their wants and needs and desires based on certain diagnoses. Take cancer, for instance. And then locally, we serve East Baltimore. So we take our community health needs assessment. For those of you who are listening who may not be familiar with this, it's a federal regulation that you take the temperature of your community and find out from them what their health needs are. We take it very seriously at Hopkins. We do surveys and focus groups and interviews with community leaders and religious leaders and patients who may be unhoused on the streets. We ask everyone and line up what they say they need based on health. Do I need help with diabetes? I need help with weight control and social determinants, which is another whole separate list. I need help with housing or food scarcity or mental or substance use disorder. And then we target our interventions based on those lists. We go back to the community. We had a town hall with the community recently where we showed them the results of what they told us. And then we said, we have ideas of what we think we should do, but we think the best ideas come from you. So we launched a grant program where community nonprofits, we will fund it, can apply for grants and help us together in partnership design interventions that they feel they need and want. So the bottom line is, just get back to it. We balance that by asking them. And I will tell you, there's an underlying theme when you really get down to brass tacks behind all those different diverse populations on what they really, really want. They want communication and they want compassion.
Mm.
And that seems to be universal across all different patient subtypes.
The two important C's, compassion and communication. And I just have a follow-up question for you, Redonda, because it sounds so simple, your answer, just ask them what they need. But if we do that, we also need to ensure that we don't create empty promises, right? That we're able to then respond to that question. So how do you do that in a way that actually can elevate the experience and then ultimately outcomes?
Well, I think the example I gave about going back to the community with what we heard and what we're now going to do is really important. And by the way, that was the first of many town halls. We plan to go back and then we'll have sessions where we talk about the outcomes of those grants and what changes have been made because you have nailed it. It's a little trickier when you're talking about an inpatient that may visit you only once for 5 or 10 days and not see from you again. But if I could create an analogy, we do it with our own staff. We ask them, we have a whole thing, your ideas at work, your opinions count, where we listen to them, town halls, engagement surveys, and then we constantly say, here's what we heard, here's what we did. Here's what we heard, here's what we did, because closing that loop is crucial.
Absolutely. That's great. And we talked about not just the Johns Hopkins Hospital operating in Baltimore, but the whole system operating internationally. And Hopkins has an expanding global footprint in providing care. So I'm interested in how you participate in some of the new ventures of bringing Hopkins physically outside of Baltimore to where people need care. And what are your thoughts on how you balance that mission of what you talked about of commitment to East Baltimore, but also the commitment to global health and global care and sharing research and clinical excellence outside of your own sort of catchment and borders?
It feels like two different missions, right? But luckily, I work at an institution where our founder, Mr. Johns Hopkins, who is a very wealthy businessman in Baltimore, died and left his $7 million to found a university and a hospital. And in his charter to the Board of Trustees, Mr. Hopkins said two things. Number one, you will be innovators. You will conduct research and spread knowledge to the world. And number two, you will be the community hospital and care for East Baltimore. So from our very birth, we knew that we had to marry both of those dualities. And honestly, I think they're more aligned than you would think on first glance. I've had such an honor of serving on our JAHA Board of Managers, and this is our Johns Hopkins Aramco Health. It is a tremendous partnership we have with Saudi Aramco in Saudi Arabia, where we help deliver healthcare to their local constituents, their local employees and their families. And I have learned so much. By the way, I should mention that's operated through our Johns Hopkins International arm. We have a whole separate business entity within Hopkins that manages this growth and this international programs and hospitals. But from my personal experience on that board of managers, I have learned so much. And you would think, oh, well, Redonda, Johns Hopkins is bringing knowledge to them. It's a two-way street. I've also learned a lot about how healthcare delivery in their country works and what lessons can I bring back here to the home institution. So I think it's very symbiotic that we do this and partner throughout the world.
Yeah, that's fantastic. It's interesting you mentioned Saudi Aramco and the Hopkins relationship because Jaha in Saudi Arabia is also certified with Planetree for Excellence in Person-Centered
I
Care.
know that. I should have
Yes.
mentioned that. And they were
Yes.
proud of it. I chair their board Patient Safety and Quality Committee, PCQC, and they are incredibly proud of that certification.
Absolutely. And that's great. And extending to Hopkins now being gold certified as well for
Yep.
multiple rounds. I just want to ask you this more sort of direct question. Hopkins clearly has not only a reputation in the US, but globally, right? For clinical excellence, great hospital, et cetera, et cetera, et cetera. Why? So, two questions. Why would you need Planetree certification? And two, how has Planetree certification and that process and the discipline of implementing person-centeredness help you and your team continuously support experience, outcomes, and your ultimate mission across Hopkins?
Well, that's it. These are good questions you ask. The first one sort of alluded to, well, why would you need Planetree certification? I think it's a validation. Here, every staff member, every colleague of mine at the hospital really puts the patient front and center. And to have that recognized by a neutral third-party organization that brings with it the highest standards really makes everyone feel proud of what they've been striving for. So I think it's very important. And then how does that person-centered care factor into sort of our day-to-day, month-to-month, year-to-year planning and what we hope to do? Well, it's infused every step of the way. And when I sit and think about, okay, FY26 and beyond, what are we going to focus on as a hospital? Well, quality and safety. The patients, the person-centered care is what drives that. Where are we not achieving what we need to do? Is it central line associated bloodstream infections? Is it hospital acquired pressure ulcers? From the patient's viewpoint, where do we need to focus and prevent harm? Then you think about operational excellence. Once again, person-centered care. Is it acceptable to have patients waiting in our ED for hours on end? No, it is not acceptable. So what are we going to do about it as a hospital? It's once again the person. What about the check-in process when they come through our front doors? Is that streamlined? Is it efficient? Is it clear on how to do it? Then if you move more towards some of our support services, it's not always the patient-facing services, but are we getting meals to patients in a timely fashion? Our patients may be NPO without food for days, waiting on procedures, or maybe they have some other condition. We need to make sure we're providing all of that support, clean linens, everything else. And then finally, part of our strategic plan is growth. Where are we going to grow? What service lines, what locations? It is person-centered. It is patient-driven because we always study what are the demands for our services and where are we not meeting those demands? Is it oncology? Is it heart and vascular? Do we have plenty of hospital beds? We don't, but and do we need more outpatient facilities? And that drives our strategic planning based upon patients, the diagnosis that they need cared for, and where they want to receive their care.
That's fantastic. I love the way you position your thinking and just want to underscore this for listeners is that you respond to safety and quality questions that are top of mind for a lot of providers, but instead of putting person-centered care as the nice to have or the separate pillar on the side, you're starting first with that as the foundation to build and support and sustain answers to those difficult questions. I know it may seem nuanced, but I think that's a really important distinction for all of us because that's how I think you've been able to support and the ongoing success and make it part of your culture and DNA. Which leads to my next question. Our work with Hopkins and your team has really stood out to us that community engagement and the voice of the patient is taken very seriously. And, a core enabler to person-centeredness and that sustainability is patient and family engagement. And something that you focused on really heavily. So could you tell us a little bit more about your PFACs and why you haven't just chosen one, how they sort of all work together to benefit your mission and agenda and the outcomes for the hospital?
Thank you for the question about our PFACs. They're a source of pride for us. We started those back in 2013, and you're right, we have 8. And one could argue, oh, 8's a lot. But honestly, they serve different parts of our organization that have different needs. For instance, we have an embedded children's center, and the needs of children and adolescents are different than the needs of adults. We have learned so much from them, and we do it in several different ways. So, retroactively, they provide feedback. Here's how, my loved one was in the hospital, and here's how you could do it better. And my leadership team takes those comments very seriously. But we don't rely on just the retroactive, or the retrospective, so to speak. We look proactively, and we make sure when we're designing new processes that we have a PFAC member by our side. For instance, we rolled out weapons detection at our entrances. You could imagine that could be very off-putting and a difficult change for patients and their families visiting our hospital.
Absolutely.
So we included our PFACs in the design of those processes, and they're not perfect yet. So we still go back to them quite frequently for help and advice and suggestions. And then, of course, our PFACs, they also are really good at helping us remember our humanity. It can be lonely to be in the hospital for days and weeks. And are we at the Johns Hopkins Hospital doing the right things to infuse a bit of humanity into their care? So recently, our adolescent PFAC decided that they need to have some milestone events for some of our teenagers who are in the hospital for a long time. So last year they had a prom. This year they had a homecoming. They bring in costume, outfits, party dresses. They do hair. They have themes. I think the theme this year for the prom is fairy tales, but they do it upright and try to bring some kind of normalcy and humanity to all the patients within our care. You also asked, though, how do they work together? Because we have 8. And they do, believe it or not. Every year we host a big annual PFAC symposium. All the PFACs come together. I attend, I usually speak, but the entire leadership of the hospital, and I'm not talking 3 or 4 or 5 people. I mean, 10, 12 of us sit down, have dinner. They share best practices. We learn from each other, not just PFAC and hospital team, but also PFAC to PFAC. And one will say, oh, well, I have this idea. And luckily, our patient experience folks here are really good about disseminating that among the different PFACs so that they also help each other.
I love that. It's so great, sort of the collective knowledge and experiences that we can bring together. I also like how you're focused on hospitals aren't normal places, and we're taking the normalcy and humanity away, poking and prodding and doing all these things that aren't pleasant, but focusing, especially from Anjantiri, our founder, who founded Planetree to restore the humanity to a human-driven process and human healing, is great to see that come to life in such a busy and well-renowned organization. Just another question as we're getting to sort of the end of our discussion. All of this wouldn't be possible without the dedicated staff to make this happen. You're talking about expanding services into oncology and vascular and how we improve the experience. How do we not forget about the human on the other side, taking care of people within our care and within our community? And how do you ensure that that is also front and center and we don't lose sight of it?
Someone once told me, and it rings true every day, that if you're not in a good place, you as a caregiver, as a provider, if you're not in a good place, how can you possibly take good care of someone else? So we focus a lot around the Johns Hopkins Hospital on wellness, making sure our staff have what they need to be successful. And certainly there are foundational things. For instance, do you have the equipment you need? Do you have the resources at the bedside? But it's more than that. It's making sure that our staff feel that they are well cared for. We all have challenges in our personal lives. So do we have the right resources to help them? The employee assistance program here at the Johns Hopkins Health System is one we're proud of, whether it's emergency funds, lots of different ways to apply resources. But then also wellness encompasses, gosh, I'm having a really bad day and I just need a break. So we developed our RISE Center. RISE stands for Resistance in Stressful Events. We have a RISE team that are a group of volunteers here at the hospital that will go to a unit. Maybe they had an unexpected death or an unexpected tragedy and deliver that peer-to-peer support that you need. But now in our RISE center, you can book a room. You can go sit in a massage chair. You can do meditation. We have a tune bed that does sound. I'm not good at this, but all that good. In fact, now that I say it, I should probably go there myself. We have an art room for art therapy. We have private meeting spaces if you want to meet a counselor. So that's been a huge success, and we're looking to expand. But your point about, gosh, you can't take good care of patients if you don't take care of yourself first really resonates with us.
That's fantastic. I love that concept of RISE. Hopefully, we get some questions on that or can share that amongst our Planetree network afterwards. Such a great idea. Before I hand it back to Chris, I have one more question for you. It seems like, and you mentioned this in the beginning, that healthcare is becoming more transactional, more depersonalized, more about cutting costs, more about pushing more through the system as much as we can to stay financially viable so that we can grow, et cetera, et cetera. So I imagine all of these pressures on your agenda as a hospital executive that then are shared with everyone throughout the organization can be really difficult to manage. How do you wrap up and stay focused on bringing the person back into it, ensuring that we are, as providers, are maintaining humanity for the people giving and receiving care? And how can we not sort of get sucked into the day-to-day of those really difficult cuts and transactional nature of where healthcare is moving potentially?
Yeah, it has been an interesting decade or two in healthcare where it feels very volume-based, transactional, more is better. And I have really good hope for the future as we as a country transition to more value-based care, where we're thinking about outcomes instead of numbers. There is some real benefit to that. And I think about patients with diabetes. We could choose to pay based on how many diabetic patients can you see in an afternoon. And if you see 12 instead of 8, then you're rewarded. Or we could choose to pay on outcomes. And does the cohort of patients with diabetes, what happens with their hemoglobin A1C? Does it fall? Do you prevent complications such as neuropathy and nephropathy? And when you shift the focus, then you as a provider are going to be focused more on, I need to spend time with the patient. I need to know the patient. Why aren't they able to get their insulin? Why are they, is it a financial issue? Is it, something else I can intervene on? Did I take the time to educate about diabetes or send them to my colleague in nutrition? Focusing on the whole patient and every aspect of successfully managing diabetes instead of the number. I use diabetes as an example. I think it could apply honestly to pretty much any disease entity, and not just outpatient, but inpatient as well. Are we hospitals making sure when we discharge a patient that the patient with diabetes has what they need? Do they have access to a podiatrist? Do they have the right appointments? Do they have? So I have hope that our healthcare system is slowly going in that direction, and that we'll have more meaningful outcomes that drive us.
That's fantastic. And I love the optimism because we all need that to keep us going. But you're right. This is not about a number and pushing volume through, but that person behind what that episode or claim or whatever it may be that we get caught up in, and how can we think differently about keeping people healthier in our care and our community. So thank you so much, Redonda, for that discussion. I do want to ensure that we take, I'm sure, a lot of questions from the audience. So I'll hand it now back to Chris to field those questions. Thanks, Chris.
Thanks, Michael. We have had a couple of questions come in. First, from Diane Blumenthal. She asks, what are your thoughts about rural health? Now, Johns Hopkins is obviously an urban medical center and so forth, but does in your research or innovation work touch on health for rural communities in any way?
Thank you for your question. And you're right. I do have thoughts about rural healthcare. And it's not so different in a sense from providing care within an urban environment, in the sense that, I grew up in a very rural area of Ohio. And so access to healthy food, access to providers, physicians, nurses, advanced practice providers. That scarcity is common, not just in urban environments, but rural as well. So I do think, and at least, some of the issues with rural environments is simply these sparsely populated areas where, once again, in a volume payment driven model, the volume isn't there. So we have to figure out as a country how to make sure we are incentivizing hospitals, healthcare systems, physician practices to be there. But the underlying problems are not that different.
Here's another question, this one anonymous. She writes, as a patient, I will occasionally try to connect with my providers through a little story or question. For example, a story about how my cat apparently has a taste for TPN, or what is their favorite Disney movie. There are times when I've gotten kind of a clinicalized response or kind of an abrupt kind of diversion, if you will. And she understands that hospitals are very busy and providers have to consider their self-preservation, but it doesn't kind of encourage further relationship building. And is that something that you think is significant in the hospital's goal and mission?
Oh my gosh, that question means a lot to me. So thank you for asking that. I'm an internist. I have my own practice. I have patients now I've known over 25 years, and I adore them. I don't know if they adore me, but that kind of getting to know people on a personal basis that is being described is crucial. I like to pride myself a little bit on knowing my patients, where their kids are, or who their pets are, and where they last took their big trip, because you know what, knowing someone on a personal level breeds trust. And trust is foundational to following advice or suggestions or recommendations. I always get a kick out of it because my own patients, I may have something I need to refer to a specialist because I don't know the answer. And so I need expert advice, maybe from a cardiologist. And it's so cute. Some of my patients will call me and said, okay, I met with the cardiologist, like you said, and they're recommending this. But I told him I'm not going to do it until I talk to you first. And I laugh because the cardiologist has a lot more knowledge than I do, but they're meeting the patient one time. I've known the patient 20 years. And so that trust, when I say, yes, do what the cardiologist says, that trust is the little push they need then to take that next step in their care. We also learned this during COVID. And if you will indulge me, I just want to brag about a program started by Elizabeth Tracy and Brian Garibaldi here at Hopkins. And it's called This Is My Story. Tim's This Is My Story. During COVID, we had great challenges with visitors. All hospitals did, not just mine, but trying to keep patients safe and keep COVID out. We had to really restrict visitation. None of us liked it. The staff hated it. We all did, but it had to be done. And so they came up. What was missing was this ability to get to know the patient. Our patients with COVID were prone, face down, on a ventilator, couldn't speak, and no family around to say, hey, little Joey's favorite stuffed animal is the dragon. Or, mom really takes pride in this, and I brought in a picture of her favorite blanket. So Elizabeth Tracy went around and did videotapes, little short 2 to 3 minute segments with family members that could tell the staff something about that patient before them because they couldn't speak. And we embedded that in our electronic medical record. And so if you're a nurse coming onto shift, you could get medical report from your colleague, but you could also go listen to that snippet about the patient and what's important and meaningful to the patient. And I can't help but think that allowed us to provide really excellent COVID care. We continued that program to this day.
Fantastic. Here's a follow-up question that's right on point from Marcelo Santoni. How can we objectively measure and improve the soft skills that are so necessary for our employees to provide excellent care to patients?
Wow, that is a fantastic question. Upon hire, there are ways that you can assess someone's natural tendencies. Are they more people-oriented? Are they more introspective, more data perhaps? And so using those kinds of tools at hire can be very helpful in shepherding a person into the position where they're going to be most fulfilled and that they'll have the biggest impact. And so those are always great tools to use. But then once you're on the job, that is a fantastic question. We pride ourselves on training people, but how do you follow up and make sure that's been done? We definitely rely on patient surveys to tell us. So I would encourage anyone who's listening who is a family member or a patient to please fill those out. We read the comments and take them seriously of where we can do better. Our PFACs tell us, as we talked about earlier, but I don't know if we have a really good objective way. And I'm going
Yeah,
to take that back to heart and give that some thought. So thank you for that.
of course. Here's another one from Ford Mataba. Thank you for sharing all of these details. Has the Johns Hopkins Institution been affected by the current political DEI interpretation and application?
That's a great question. And of course, everyone across the country is wrestling. We remain true to our mission. That is foundational. And absolutely are looking at what we're doing and making sure that we are, and it's not just diversity for diversity's sake, but making sure we have all the right voices around the table, and that will not change. So, yes, of course, I would be lying if I didn't say we're giving this some thought. But I can tell you with 100% certainty, we plan to remain absolutely true to our core mission.
Okay, great. Here's another one from Binny John. Dr. Miller, could you please share specific strategies or initiatives that you have implemented in your hospital to enhance staff experience?
So, yes, thank you for that question. Staff experience is really important. And I alluded to some of the work we've done on well-being. That is goes without saying, the RISE Center and some of our wellness. But staff experience is more than that. We do a lot of focus groups and management touch points to hear what's working for staff, what's not working. We've learned that our parking situation in our garage is not ideal, so we're working on fixing that. We've learned that some of our food options and the hours that we offer staff are not what they need, so we're working on that. But also, we think there's more to staff. It's wellness. It's certainly fixing pain points for them, but it's also about joy and positivity. So we launched a new group that I'm very proud of called our Spirit Ambassadors. And they are a remarkable team of volunteers. They have day jobs here around the hospital. And I gave them a budget, and they host fun celebrations just because. So last October, they had a pumpkin decorating competition. And we had, gosh, I want to say 80, 90 different entries from units all across the hospital, the cath lab, Nelson 6. And I wish you could see the pictures of these pumpkins. They were beyond elaborate. And the staff voted on them and chose winners, and there were prizes. Last summer, we did a pop-up snowball. In Baltimore, we call them snowballs, not snow cones, not shaved ice, but it's the same concept. And so myself, my CNO, CMO, CFO, everyone, we served snowballs to the entire hospital morning, noon, and night. And it was fun. And I was a sticky mess. But it was just like, let's just have a moment of levity and celebrate everyone and what we do.
One quick follow-up from M. Friesen. Could you please repeat what RISE stands for?
Yes. Resilience in stressful events. It was a program launched by Cheryl Connors and Albert Wu, two of my colleagues, and they have disseminated that work across the country. So if you're interested in bringing a RISE type program to your institution, those are the folks to contact, Cheryl Connors and Albert Wu.
Excellent. And here, this will be our last listener question. Okay. If you wanted to give one strong message to the world on person-centered care, what would it be? And that's from Miraj Shah.
Person-centered care is absolutely foundational. It should not be an afterthought, something that you sit on top of everything else you do. Instead, person-centered care should infuse all new processes, your strategic objectives. It should be the question that you ask first for anything that you're trying to fix or anything new you're launching. What would someone visiting, a staff member, a patient, a visitor, how should we do this so that their needs are served?
And so I have one final question for you. It's always our favorite to wrap up with. And that is, do you have a favorite quote? And if so, what is it and why is it your favorite?
Well, I can tell you right now, I'm going to channel Finding Nemo and say, just keep swimming, just keep swimming, just keep. But that's not my quote. So I think I trained in medicine, internal medicine, and I trained here at Hopkins on the Osler Medical Service. The Osler Medical Service was named for Sir William Osler, who is said to be a little bit of the godfather of internal medicine. He was the first one to do teaching and research at the bedside, to actually engage patients in their care, doing rounds. He developed rounds on patients. And so one of his quotes rings true with me that has stood the test of time. And I'm going to read it to you. It is much more important to know what sort of patient has a disease than what sort of disease a patient has.
Excellent advice. So, Redonda and Michael, thank you so much for such an enlightening conversation today. We're so grateful for the time and perspective that you have shared. To our listeners, thank you for joining us as well. We hope you found this discussion informative and inspiring. And be sure to register for our next Humanizing Healthcare discussion. We'll be talking with Adrian David, Chief Operating Officer of New York Blood Center, one of the nation's largest blood banks. Join us for some expertise and insights you won't hear anywhere else.